Sorry. What apologies have we got?
Emma Cockrell, Matt Pope and Andrew Statham.
Thank you. Okay, the minutes of the previous meeting. Is everyone happy with those minutes? Yes, yes. Okay, thank you very much. Anyone got any declarations of interest? We have no public or members' questions, so we can get through to the Wokingham Joint Strategic Needs Assessment Update and Forward Plan. And Sarah, yeah, I think you're doing this. It's hard having two pairs of glasses.
Yes. Just get the slides up onto the screen.
I'm a little bit surprised that the camera's not changing position, that it seems to be focused on me and Stephen.
It's not now.
Oh, it's just changed to go away. That's the wrong way round.
Still look at you and Stephen. But when I speak, it doesn't look at me. Don't know what I've done.
Okay, am I okay to start?
Yes, sorry.
Slide showing. Yeah, okay, brilliant, thank you. So I'm going to provide an update on what's been done under the JSNA programme for 24-25, as well as outlining the programme for 25-26, and this will include proposing 2 joint needs assessments to be undertaken. And I'll also just briefly describe what this process could look like as well. So, as a reminder, JSNA is a statutory responsibility of the board, with members having a joint and equal duty to produce a JSNA and to also use it as a basis for decision making. As part of this, the board can request data from members, and members have a duty to then provide that data as well. So at the moment, there are 2 strands to JSNA in Wokingham Borough, which are hosted on the Wokingham Borough Observatory. So one of these is a suite of automated data visualizations and reports, and the other is this library of local needs assessments, which provide that deeper insight into topics requiring action. So far, many of these assessments haven't fully benefited from a joint approach. So part of what we're suggesting is that in future, proposals for more joint needs assessments will be brought to the board on an annual basis, so that these can be prioritised as part of JSNA, and really just to ensure that these assessments kind of benefit from that joint focus across the system. So on this slide, what I've described here is kind of the kind of gold standard joint needs assessment process that would start by establishing what decisions the assessment is going to inform, through to a thorough analysis of data, drawing both from numeric data and views of stakeholders, including our residents, to understanding what is currently being provided, how well this is working, and what opportunities we have to make change happen. So in an ideal situation, we'd give full and equal attention to all of these elements of the process, and this would result in kind of the best and most useful assessments. And one of the main reasons for this is that no one can really answer all these questions in isolation. So it needs to be done by bringing partners together and going through this process jointly. This joint assessment process enables those conversations to happen that can then lead to conversations around those joined up solutions. However, that being said, we recognise that it's not always possible to go through this full process due to constraints, particularly around time and capacity. So not all these elements can be done, and we must choose which are most vital to include. But again, we'd emphasise the importance of doing those chosen elements as jointly as possible. I'll skip over this slide because I've already covered the process, but this is just kind of showing those indicative timescales against that kind of gold standard process. So emphasising kind of the time commitment that would be involved in that. So before looking ahead, this is what's been done around the JSNA programme through 24-25. So Public Health have completed all age autism needs assessments that supported the associated strategy. Also completed a falls prevention needs assessment on behalf of the integrated partnership, and Children's Services have led on a SEND needs assessment. So at the moment, started in 24-25, Public Health are working on 3 further needs assessments around eat well, be active, alcohol, drugs, tobacco and vaping, and health visiting and school nursing. And these will be used to inform strategy development and inform commissioning and delivery of services. Also on behalf of the board, we're leading on the pharmaceutical needs assessment, which is on the agenda for today. And finally, we're just in the process of finalising a health and wellbeing board dashboard and annual report, and that will be coming to the board in September. So going forward into the current year, we have a focus on updating 2 of the standard JSNA reports that are on the observatory. So there's one on people, one on place. Obviously completing the assessments that we've started during 24-25. And then we're proposing these 2 joint assessments to be conducted throughout this year, one around children's and one on adult social care. And we're just asking the board as well to support in contributing to these assessments as relevant as we develop that kind of programme of work. So in summary today, asking the board to note the process for producing joint needs assessments, to note the proposal that in future will bring proposals for joint assessments to the board on an annual basis for those to be prioritised as part of JSNA, and then to agree the inclusion of those 2 joint assessments on the JSNA programme for this year, so the children's needs assessment and the adult social care assessment. And finally, to agree for members to support and contribute to these as is relevant. So I will stop sharing that now and come back to the room for any questions.
Thank you very much. Has anyone got any questions? I think you've explained that excellently because I can't see any questions.
Not a question, but a comment. Thank you very much, Sarah, for that very full and helpful summary. It looks as though some good work's going on, so thank you.
Thank you.
Shall we just have Alice?
Thank you, Chair. Just Sarah, just a comment in the sense that these meetings are in public, and it would be good to have a public language kind of thing, because doing acronyms and things that doesn't help public. We will know what they mean, but the public needs to know as well. So if we can, all of us think about how we do our presentation would help. Because I was sitting here thinking some of the stuff I don't even know. So where would I go if I wanted all this stuff? So so the presentation could be made a little bit easier, an easier read, or easy with easier health literacy.
Okay. Of course, thank you. Noted. That's good comments. Was there anything in particular that I can expand on now? Or
I think like that you kept on using JSNA kind of thing. Whether we like it or not, we have to we should never make assumptions that people know.
Yeah, of course. So sorry, everybody. So that was referring to the Joint Strategic Needs Assessment process, which is a process of kind of identifying population need in order to plan strategies and services to best meet those needs identified. Thanks, Alice.
Thank you. I think Ben has a comment.
Hi, I'm Ben Riley. I'm the Chief Medical Officer at the BOB Integrated Care Board. So BOB stands for Buckinghamshire, Oxfordshire and Berkshire West. But it was just to note really that one of the big priorities this year is around neighbourhood health development for the NHS. And in fact, we discussed it at the Integrated Care Board meeting only a few days ago. And these sorts of needs assessment, in fact, the first of the sort of priorities within that programme is around establishing good local data and processes to understand the needs of the local community and the neighbourhoods. And I think that these will be really valuable for that, and I think it's good to bring them all together and have that sort of strategic approach to, and also bring it with the sort of public aspect of this board as well will obviously help people to understand what's informing the decisions around neighbourhood working as well.
Yeah, great. Yeah, thank you. And that's a key part of the joint strategic needs assessment, is that we're evidencing how we're making those decisions based on needs. So thank you.
Susan.
Thank you, Susan Parsonage, Chief Executive at Wokingham Borough Council. It's with regards to the two pieces of work that you've put forward to focus on children's and adult social care. I just wondered if you could say a little bit more about what you think the needs analysis will show us. I know you won't know all of the detail, but give a sense of the type of thing that those assessments might show us for children and adult social care.
So I think to answer that, I'd say Jyoti might want to come in as well, but I think the key to that is firstly understanding the questions that we want to ask of that assessment. I think that's a key part of starting that journey to understand what it is that we need to answer, and I think that will be established through those working groups that will be formed as part of the needs assessment process.
Jyoti, have you got something to say?
Yeah, I was just going to say that the importance of these needs assessments are that they are joint, and some of the questions will need to come from the service managers who are closer to the service, understand their local needs, which could then lead us to interrogate the data further to support us in developing solutions to any issues that we identify. Yeah, I think we can't really preempt to the outcomes until we've done the work, as you've said, Susan.
Yeah, I absolutely understand that. Jyoti, is it, in terms of, because of your experience in other areas, I mean, are the things that you may have found in other areas through doing a joint strategic needs assessment, say, for example, around children's and adults?
Yeah, I mean, it will, for children's, it will depend. In some places I've worked, we've known we've got a growing children's population, and then that, affects how you might plan for school places, etc. Mm-hmm. Mental health has been a common theme for children. Worsening mental health post-pandemic, poorer school attendance post-pandemic, difficulties in accessing mental health services, very long waits for mental health services. That's been a strong theme that's come out in pieces of work I've done before. In terms of the adult social care here, we know there's a growing older population, which will continue to put additional demands on health and social care. And growing older women tend to end up more in residential care, from work I've done in other places, than men. Often because they've outlived their partners and don't have social support available to them. So they're the sorts of themes that have come up in previous similar needs assessments I've done.
Thank you.
Okay, that looks like no more questions. Thank you very much for that, Sarah. And I believe you're doing the next one as well about. Well, we've got to.
Yes.
Sorry. Yes, we've got to agree. The recommendations. So, do we need a proposal in second, or just agree it? Is everyone in agreement with those recommendations? Okay, thank you very much. Sorry about that. Okay, thank you, Sarah. And now we've got the pharmaceutical needs assessment, which we're going to do.
Yes. Yes. So. Yes, as a reminder, the board has a statutory responsibility to publish a pharmaceutical needs assessment, or P&A, every 3 years. So the current P&A is requiring update by the 1st of October of this year. So one of the main uses of a P&A is for commissioners of services to determine if new pharmacies or services are needed to meet the needs of the population. So back in November, the board discharged its duty to deliver the P&A, including the sign-off of the consultation draft, to a steering group, and the final post-consultation draft will come back to this board in September for final sign-off. So the papers shared provides an update on the P&A. and we're bringing this today as we're at a key milestone with the draft ready to go for consultation. So I'll just summarise some of the key findings, conclusions and next steps that were outlined in the paper. So in terms of key findings, there are 20 pharmacies in the borough. So since the last P&A was conducted 3 years ago, 3 pharmacies have closed, but those closures were then shortly followed by a new pharmacy opening either at the same or near to the same site, so that there's not been a net loss in number of pharmacies. We did have one pharmacy that was included in the previous P&A that further analysis can reveal that that is now actually covered within Reading Borough. So that isn't included in the P&A this time round, although it's still there existing and providing services to residents, including Wokingham residents. So we do have a lower than average rate of pharmacies per population when we compare that to England. But we have determined that pharmacies are located within kind of main population centres, and that they're further supplemented by GP practices dispensing out of 6 sites, providing those services to our more rural communities. It was also found that many pharmacies in the borough are open evenings, open weekends, and open for extended hours. So, for example, 20% of Wokingham Borough pharmacies hold a 72+ hour contract, compared to an average in England of 7% of pharmacies. We found through travel time analysis and also through a public survey that was conducted that most residents are able to access a pharmacy within 20 to 30 minutes using a range of modes of transport, and that most pharmacies provide advanced and enhanced services such as the Pharmacy First, flu vaccination service, in addition to those essential services that must be provided. The P&A also does consider projected growth, particularly as a result of housing development over the lifetime of the P&A, so those 3 years. And it was determined that the community pharmacy network is currently able to accommodate this growth, supported by the pharmacy's kind of ability to adjust staffing and service delivery models where necessary. So overall, the draft P&A concludes that there are no gaps in community pharmacy services now, and they're not anticipated to be gaps over the lifetime of the P&A, so that 3 years. So firstly today, I'm asking the board to note these conclusions and findings, and also to note the next steps, which are to be a 60-day consultation, which will start on the 27th of May. This consultation will be directly promoted to a list of statutory consultees, so pharmacy contractors, dispensing doctors, and it will also be publicly available for wider comment, including comment from residents. And we're going to support that through production of an easy read version of the P&A to make that more accessible. And then a consultation report will determine if any changes need to be made to the draft. And then, as I said, the final report will come back to this board in September. So we'll share that prior to that board, 2 weeks prior. And then the final stage will be the P&A being published on the Wokingham Observatory site in time for that 1st of October deadline. So that's the update on P&A. Thank you.
Thank you very much, Sarah. I'm going to take my position because I was very worried by the fact that 10.8 compared to 18.1 per 100,000 is quite a big difference. Now I know they're well spread. I know that most people in Wokingham have cars and it isn't too hard for most people, but the people who need to get to pharmacies, and that's especially older people who might not drive, people with disabilities who might not drive, things like that, I would think sometimes find it very hard to access a pharmacy near them. Have you got any comments?
Yes, so I think firstly the using that rate is a difficult comparison in a way. I know some areas choose not to make that comparison, and we did decide that we would include it in the PNA, because it's that difficulty, I suppose, of comparing Wokingham or any other area to that England average. The average doesn't take into account how urban, how rural an area is. It doesn't include any of the kind of dispensing practices, of which we have kind of 6 sites that are from dispensing practices, so that isn't included in that figure as well. We did conduct a survey with the public as part of the PNA, and that was, we did get quite a good response rate to that. I think over 1,000 responses, and that didn't indicate any real kind of red flags in terms of access and travel times again, which kind of supported what we did through the more formal travel time analysis as well.
Thank you, Sarah. Okay. Prue, and then...
Well, thank you very much. It was just to welcome the finding that there weren't any current gaps. I do take the point on board, though, that there is a need to keep a close eye on that, because it looks like the number has dropped slightly since the last assessment, so we will need to sort of keep a close eye on that. I was glad that you referenced some of the new roles of pharmacies around the sort of pharmacy first scheme, for example, and that, for those who aren't aware, that's a scheme under which pharmacies are able to treat people with a range of minor ailments or illnesses directly, without the patient having to go to their GP first. And I think that's playing a really important role in supporting practices, particularly with the sort of what we call the same day demand. So, you know, when people need an appointment on the day for something that actually maybe doesn't need to see a GP, you know, as a doctor, but it could be treated by another professional. Just looking ahead, it's quite likely, I think, that scheme will expand over the coming years, because it's proving quite successful. So that's another reason why local access to pharmacy is going to be really important. And then the other change that's happening is that new pharmacists who are being trained are going to come out of their training with what we call independent prescribing status, which means that they can actually write prescriptions for things like antibiotics, for example. So again, that will further expand in the future what the treatments that pharmacies can provide. So it will become really important, I think, that there's a really strong pharmacy network in the community.
Thank you. Yes, and I should say that the PNA will then be going forward is monitored through a kind of supplementary statement process. So if there's any significant change in that provision or need, the board is required to then add a supplementary statement to the assessment to update and include that as well.
Thank you. Prue.
Thank you, David. We're in one of the areas which has got one of the new pharmacies that opened after the other one closed. And as it happens, I was in there only yesterday. They are absolutely heaving with people. It didn't stop. They've got 3 people. They had queues yesterday. They're doing a really good service. They were offering these other things. Yesterday was a blood pressure test day. And it's really good to see. They're providing a really good service. What I am concerned about is that there's a lot of reference at the moment to the fact that the contract that the government has with the pharmacists, they are losing money on every medicine that they supply. It's just not a feasible model to continue with. So while we might look okay at the moment, there is every risk that some of those pharmacies won't be able to continue because they are losing money hand over fist. They have to do a lot of other things, and they rely on those other things in order to keep their income up. But it's not a sensible proposition to find that you're not given enough for the medicines you have to buy to actually cover the cost of them, let alone anything that you'd have to do to cover your own costs on top. So I don't know what we can do about that, because it doesn't come out in the needs assessment, which is a really quite a technical thing. but I don't know where we can raise it as a health and wellbeing board, because it's just not sensible to go on like that.
Should we?
Thanks. Yeah, that is, all those issues are definitely something that the ICB is very aware of, and as you say, it has been tough for pharmacies recently, and with the national contract issues. I think that's another reason why some of these other income sources are quite important for pharmacies. I think it's also been exacerbated by things like the rise of online pharmacies. People are ordering their medications online, increasingly getting them delivered, and that could be based anywhere and not locally. And also the shortages that we've seen, particularly since the pandemic, around certain drugs not being available, the manufacturing challenges and the supply chain issues that have been in the news, also means that they then sometimes have to purchase things at a higher cost, and then that affects their profit as well. So there are real challenges. But in terms of raising it, it's definitely something the ICB is keeping a close eye on.
Would it be worth us writing to the ICB to just jog them, say we're in those things as well as perhaps our MP and the Minister responsible for pharmacies as well? Because, if they get letters, they start to think, oh yes, people realise that this is a problem, not just for the pharmacies, but for us, because we want to keep the pharmacies and we might well lose them.
Can't see any harm in doing that.
Thank you. Stephen.
Thank you, David. My question really, or comment, it's partly a question, partly a comment, relates to future changes. We know there is going to be significant housing growth in the borough. Certainly over the next 3 years there will be some of that growth, and there will be more following on afterwards. That is an inescapable fact. And I suppose it's just trying to get in early so that we can plan future provision in those areas where it's going to be needed. And coming back to really the points that have been raised already about the importance of pharmacies, clearly they now have an enhanced role in providing some primary health care and reducing pressure on the NHS. They are under some financial pressure themselves. We do need to recognise also that pharmacies are an integral part in communities. I think they help create a sense of a community, because pharmacies, everyone in a community will use them at some stage or another. Everyone will experience illness and require a visit to a pharmacist. So I suppose it's just getting a little bit of reassurance that we're building into our future plans for housing delivery, even in this 3-year period we're talking about here, sufficient pharmacy provision, bearing in mind that to create new communities is an important part of the planning process. It's not just about putting up the required number of houses, it's about creating real communities, and communities, I think, need pharmacies to feel they are part of a community. So I don't know whether there's anything, you say, or the report says, sorry Sarah, you didn't say it, but the report says key stages of the project, this is on page 22, key stages of the project plan completed so far. So it looks as though an assessment has already been done on likely future need. Has that revealed a need for additional pharmacy provision in particular places?
So that has been done, and we did conclude that there isn't a need for additional pharmacies to support that growth. Though the P&A does acknowledge that that existing pharmacies may need to kind of flex in order to meet that demand. And then within the P&A document, as well as also some recommendations of what that support to pharmacies could look like as well to enable that to happen.
If I could just quickly come back, I think, I understand that obviously worked out on a population growth basis, which is the way you have to do this. We look as though we've probably got enough pharmacies at present, but I suppose I was trying to introduce into the discussion, I don't know whether this is a factor you're allowed to take into account, but community building in the sense of creating communities as opposed to simply creating buildings, does require things like key infrastructure around community support. So a pharmacy would be part of that. So where we are planning large-scale new development, I hope we might be able to take into account that even if in overall demographic terms we have enough, do we have enough provision in exactly the right places?
Yes, so the P&A does consider the location of pharmacies as well in relation to population centres, and again did conclude that they were located in the right places, with the addition of the dispensing GP practices, which are located in more rural areas. But the P&A, in terms of its assessment of gaps, it is based on that kind of geography and the times and days in which services are provided. So that's kind of the basis on which it makes its conclusions.
Thank you.
I think, oh, George.
Thanks, David. I think hopefully you can hear me okay. The 4 points. I think Stephen's kind of said what I was thinking about, just being aware of the kind of population growth, not just in the next 3 years, but beyond that, and whether outside of this process there's kind of pre-thinking about what is going to be needed beyond 2028, so that we're kind of well ahead, I guess, of any future formal process, and just being really clear about the significant growth within the borough. The second point I think kind of Prue touched on, which is a kind of capacity point. So it sounds like we've got the pharmacies in the right locations, but is the capacity right? I'm not sure if this answers that or needs to answer that, but it was just a question for me. And as intensification happens in certain areas, that capacity, you said some need to flex, you said, but it's just kind of being aware of that and whether we can be more aware of that. Two more points. One is, we often have talked about in wellbeing forums about the average, and I didn't know if this or a future document would benefit from kind of really understanding where perhaps the most need for these facilities are, so those communities that are in most need and have a clear demand on pharmacies, and just making sure that the pharmacies are at the right location for those communities and have the right capacity for those locations as well. So it's okay for me, I can drop in my car, I can drive half an hour to that, but if I wasn't able to drive and I needed services more and I was less able to and less mobile, then and in that kind of community, so I don't know if there's a kind of more granular approach we can take. And then finally, a very detailed point, it says that 76% can reach a pharmacy within 30 minutes during peak times, but that increases at off-peak times. I guess it's the other way round, is it? I'm assuming fewer can go access off-peak, given through public transport. It doesn't sound quite right to me. So
yeah, so that might be my error. Yes, sorry. I think that should be the other way around. Yes, you're right. Yeah.
Okay.
And in terms of the other questions, so the P&A doesn't make its assessment based on capacity. It does look at, like I say, a more based on geography and times of days which services are provided. In terms of looking into those inequalities, yeah, I agree there could be future scope to look more into that. At the moment, the P&A does look at more kind of higher kind of population level needs. Probably the exception to that is that the public consultation survey that we did collect kind of protected characteristics data as part of that, and that analysis was then done based on the kind of a comparison between those groups, which didn't find any really significant differences. That being said, it was a sample size of about 1,000 people, so it wasn't. It was a good response to a PNA survey, but wasn't a huge sample size. Yeah, so that's something that we could look at in the future. Yeah.
Susan, sorry, yes.
Thank you very much. Just wanted to ask a question about the point you make in the report about some of the pharmacies that are in the rural areas, and there's access to dispensing doctor practice sites in some areas.
Yeah.
I guess my question is, given that we're in terms of population-wise, we're below average in terms of the number of pharmacies. Is this putting a pressure on GP services that we know are already under intense pressure, given that point that you're making about in some places there is, that access to dispensing doctor practices?
So the dispensing doctor practices will only be accessible by the population registered within those practices, right. Which is why we can't include them in that kind of rate per population figure. There's statutory consultees as part of the draft P&A include dispensing GP practices and the local medical council. So we will be asking for their views around that as well, but that hasn't been done yet as part of the P&A. That will come through the consultation.
Okay, thanks. Can I just clarify something? Because I was assuming, so dispensing doctor practice site is a doctor's. I mean, I don't. Maybe you could clarify that for me. Yeah, I just wanted to check just to make sure I'd understood correctly.
Yes. Sorry. Yes. So they are GP practices or their branch practices. Yeah.
Okay. Thank you.
One more point. It's a tiny point, but I'll raise it now. Sorry. Thanks. Both this report and the one before have had references to the observatory in it, and I think it would be really handy if we had something in all our agendas which was the link to the observatory, because an awful lot of the things that we deal with, the data is on there somewhere.
Yes.
So it's not really perhaps in the individual items, but somewhere in the agenda, we could put that in and people could find it then.
Thank you, Prue. That would be very useful. Okay, I think that's all the questions. Thank you very much, Sarah, for those two. And we look forward to seeing you again. Okay. We're now going to look at marmots, and I believe that's Louise.
That is me, thank you. I my presentation, but I think, am I sharing my own screen? Is that how it works best? I will just do that now. Withhold my breath when I'm doing this, because we've been doing it for 5 years now, haven't we? And
It's worked.
Oh, can breathe again. Right, now if I put that onto slideshow, that will help, won't it? There we go. Can you see that? I can't see anyone now, I'm afraid, so please do just shout out if things aren't moving on, or you can't hear, or you have a kind of a clarification question or anything. But is that showing now?
Yes.
Brilliant. Phew. Let's go then. So I'm Louise. Thank you for the invite to speak tonight. I'm public health consultant in the public health team in the council. I started sort of late last year, and my portfolio covers the building blocks of health and inequalities, and this work around marmots. And I know obviously you've previously heard about Marmot becoming a marmot borough, and I'm here just to give, I think we haven't got long, but to give a bit of a recap on what this means, as well as a very brief recap on the strands of work that informed scoping, to share some of the initial recommendations that Wokingham Borough has received from the Institute of Health Equity, sorry, I should say the council has received from the Institute of Health Equity, and how we thought about the council's approach to adopting the marmot approach. To give a sort of very brief mention of a couple of areas of activity, and then would ask that we have think in the discussion about the role of the Health and Wellbeing Board in Marmot Borough. So a quick recap on what a Marmot Borough is. So that's on the slide really. It's a place that recognises that our ability to thrive, our ability to live healthy lives, to have good well-being is shaped by those conditions in which we're born, grow, live, work, age, all of these things that we think of as building blocks of our health. So they all need to be robustly in place, they all interact to give us those opportunities to live healthier lives, to have good well-being, to thrive really. And a Marmot Borough also, I think, where Marmot Place takes action, that's important, takes action to improve outcomes for everyone, but really with a focus on some of those with the greatest need or greater need and worse outcomes. So the Marmot we refer to is Professor Sir Michael Marmot from the Institute of Health Equity at University College London. He carried out a big seminal review of health inequalities in England back in 2010 and then updated this in 2020. And that review identified a set of evidence-based principles for improving health equity, improving everyone's opportunities to live healthier lives. And these principles, which are up on the screen now, hopefully have moved along, really span the whole of the life course and think about creating healthy places and also the role of the health system and ill health prevention. And I think cutting across all of those really are the importance of tackling racism, discrimination and the outcomes of these, and also how we think about the health of the planet. So how do we think about healthy people and healthy places sort of hand in hand across everything we do. So as you're aware, we've been working with the support of the team at the Institute of Health Equity to think about what these principles mean in Wokingham Borough, how we can adopt these principles, and importantly, how we can work maybe as a system, which would be great to discuss today, to improve everyone's opportunities to thrive in the borough. So this slide, and I know you've had all these slides and more in your pack, so I'm not going to sort of read everything out, but I'm really happy to take questions on any of the wider pack as well, or have follow-up conversations. This slide represents a key principle in addressing health inequalities and introduces better terminology. So the Marmot Review really emphasises the importance of providing support that's proportionate to levels of need. So apologies to use jargon now, but introducing a bit of jargon. They use the term proportionate universalism. So that means providing support or help that is proportionate to the level of need, as well as sort of universal action to support people and to remove barriers, I think, for thriving. This isn't just fully about targeting those people with the very worst outcomes and the greatest need, but really about thinking across the full spectrum or the full gradient of people's outcomes and needs. A number of work streams have informed our understanding to date of inequalities that exist in the borough and shaped the approach. So that's really about understanding the inequalities, understanding how our residents experience these, which is really important. Also some of the opportunities that exist, and initially this is a lot of this is focused within the council work. I think you've heard a bit about some of these previously, forgive me if not, but as a reminder, what these have included is looking at data, how we use data and intelligence so that we can understand inequalities in outcomes and also in the things that influence these outcomes in different communities in the borough. So for example, the Berkshire Observatory now has measures disaggregated down for different groups, so broken down by different groups, and a set of slides on some of the unfair and avoidable differences that exist in those building blocks of health for people in the borough. And the dashboard, the Health and Wellbeing Board dashboard that Sarah mentioned, will show these inequalities as well. Our insights work there has involved working with and listening to residents and people who work very closely with residents who might be facing particular challenges in the borough. And I don't know if you've seen it yet, but in development is an incredible animation that's been created using their words and art to really share how people experience the borough in different ways. We've also mapped out sort of areas of work across Woking Borough Council to those Marmot principles. And then sort of taking all of that, we've worked with the Institute of Health Equity to identify some key opportunities within all of this. Institute of Health Equity have made a sort of set of initial recommendations to the council. It's been working hand in hand with them, looking at all those sort of streams of work and thinking about where the opportunities lie. Clearly, as I said, to effectively improve health equity in the borough, we need to work as a system and as a partner in a system. And I'll come back to this as I talk through his recommendations and in the discussion, I hope. But initially, what some of this considers as some of the opportunities we've been looking at within the council, and a lot of this work is well underway. So recommendations here to embed the commitment to reduce inequalities in the council plan, to think about leadership and ownership for this across the council, to think about models of delivery of services and support that really focus on early intervention, prevention, and understanding need and providing support that's proportionate to that need. I'm not just going to read out everything on the slide. I've talked a bit about data, talked about sort of partnership, and one area of focus they sort of picked up from the data was around educational outcomes and skills and employment training. So that's one area of focus. But as I said, we need to work as a partner within the system if we're going to achieve the ambition of reducing inequalities. And this is really the focus of these sort of next steps set of recommendations from the Institute of Health Equity, really to think about how equity can be embedded in partnership working with partners, including everyone around this table, and more and importantly with our residents and communities. Oh, right. Right. Okay, and this is a way of visualising, I think, how we've translated some of those recommendations into sort of multi-layered approach and how we're thinking about this. And we discussed this with the corporate leadership team and executive members late last year. So we've just sort of going from the inside out, and obviously a lot of this is thinking about, how do we meet the ambitions within the community's vision and the ambitions of those residents that are obviously at the heart of everything we do. So we've had a really timely opportunity this year with the development of our new council plan, and thinking about how we really embed the Marmot principles into that, and without kind of using the word Marmot approach, because it is jargon and it doesn't mean much, and a lot of people think of the small furry animals when we say Marmot, or they think about Marmite. So really thinking about how we have kind of translated some of that approach and those evidence-based principles into the kind of breadth of the priorities and into the principles of working. We've identified a handful of strategic areas of work that are both timely and match those Marmot principles and provide good opportunities. So thinking about our skills strategy and development of a skills strategy, and how can we support everyone in the borough to develop skills they need to live the lives they want and to sort of achieve their goals. We're thinking about the adult social care strategy and how we really bring these Marmot principles into the needs assessment for that, and more as well. So it's really about thinking about these are key areas to adopt these principles, and they're also opportunities to learn how it looks different. How does our strategy or programme development look different if we do it through this lens of equity? Around all that and underpinning all of that is obviously the importance, as you've heard, of understanding those inequalities, those unfair and avoidable differences that exist. So how do we look at data? How do we break data down to look at it for different groups? How do we use insights from residents? And how do we use all that not only to understand the current situation, but to think about how we monitor and understand if we are being successful in our goal of helping everyone to thrive? And then around all that, and key to all of this, is the partnership development and working. So, as I've mentioned, building equity, building a borough where everyone can thrive requires action across all those building blocks. It requires consideration of those Marmot principles. They're really broad. It's work that we need to do in partnership, and think about all of the contributions that we make and how we work as a system. Just to sort of kick off some discussion, and of course any questions are really welcome, but would like to ask the board to really think about considering the role in Marmot Borough, including the governance of some of this, and whether the board would be open to doing a workshop or some other form of work with the Institute of Health Equity to really think about the role of the board and the partnerships represented in building a borough where everyone can thrive. I'm going to stop sharing because I can't see anyone. And please, any questions or comments and thoughts on the role of the board?
Thank you very much, Louise. And certainly, Jyoti and I were talking about having some kind of bigger meeting about what Marmot means and what it means to people outside the council as well as inside the council. Are we taking it through the council, because it's not just health, it's not just children's work, it's everything, but also it needs to go outside so that people can see the need to perhaps change some of their practices as well. So it's something which is universal rather than just specific to the council, I think. But thank you very much. Are there any questions, Stephen?
Well, again, thank you, Louise, for that presentation. This isn't really so much a question as an answer to your question about whether we would be interested in engaging with the Institute of Health Equity and getting their advice, setting up a meeting with them so we could really discuss how we can optimise governance arrangements and particularly the role of this board. I would very much welcome that. I think we could gain greatly if we engage as a board with the Institute of Health Equity. So from a personal perspective, I would think that was a very positive step forward if we could do that.
That's wonderful to hear. Thank you. And yeah, their sort of model of often working is to sort of come into place really to, you know, bring system partners together to really workshop sort of priorities, understand the role of the different system partners, and importantly to help develop action plans to think about how it's monitored, how it's measured. So, you know, probably a kind of initial workshop and then thinking about appetite for a further process, or maybe which partnerships could do some more detailed work with. So we can go about arranging that if there's sort of consensus about this.
I've got a workshop on Tuesday with WHIP, which is including.
Great.
So I'll report back to you after that. But I think it's very important that as a group we also have something like that, so that we can know how we're going forward.
Super. Yes, I will be there on Tuesday, so I'm very much looking forward to that and to seeing you, so we can have a catch up. Yeah, sorry not to be there in the room this evening.
Okay, thank you. Is that Alice? Alice?
Yes, Chair. Thank you very much. Thank you, Louise, for this. I mean, this day and age, we are all challenging with funds and things like that. How is this going to be funded? Because another new initiative, you know, is one. So, you know, we need to turn around and think about this, because, you know, how are you going to communicate to the community that this is of value? So, because all this comes down to money. You know, even the charity sector are struggling with money.
Yeah. Philip, is your question related? Do you want me to take that, or shall I answer this first?
No, that's absolutely fine. If you want to answer Alice, that'd be great. Thank you, Louise.
Alice, a really good question. And so the resource from the Institute of Health Equity is already secured. That's funded through the council through this year. And this, I need to say, is not about sort of another initiative. We're very keen that this, you know, there's a longer term thing around culture change. It's about how we embed this in existing areas of work and how we work together more effectively. So yeah, the support from Institute of Health Equity is already funded. I'm in and working sort of across the council, and we want to use this period of this year while we've got that support to be able to really think about how we embed this, how we do it going forward in the things that we're all, you know, are doing. Some of that might be things that, you know, are not contributing to this. And then we think, do we keep doing, you know, but it's very much about long-term culture change, bringing a different perspective, a different pair of glasses to what we are doing already, thinking across, you know, that's why we've sort of mapped out the opportunities within the council. It'd be great to do that within the partners. What are the areas of work that are going on? what are the inequalities that are maybe being seen by different partners. You know, we've all got a different part of the puzzle, I think, and how can we sort of coalesce around this and really think about a shared commitment and how we can tackle it through what we already have going on. Does that answer your question?
It does, and I mean the thing that I have is everybody's struggling for funds and things like that, and then bringing this in, it's how do you benefit? How do we benefit? What is your, I saw the outcome, what your one plan, but a lot of people live in the present, not the future, and how do you engage with that to convince people that this is the right way of going?
The right approach and right to be tackling inequalities. And that is exactly right. We need to effectively make that case. This is why the piece of data work is so important and the insight work, because, on the face of it, we're a healthy and affluent borough. You look across our indicators, they're all green. You could say, good job done, we're doing well. But actually digging beneath that surface, showing some of those unfair, some of those avoidable differences that exist both in people's outcomes and in their opportunities to thrive, really reveals that need, and understanding how action to sort of strengthen all of these building blocks, or to provide services in a way that directly addresses that need or those levels of need, help us to shift in a slightly different way within what we're already doing, to close some of those gaps. So yeah, there's a piece of case making that understanding supports that. Also understanding the evidence that this isn't inevitable and there is a lot that we can do. A lot of which is about how we do what we're already doing to close those gaps.
Thank you.
Thank you.
Stephen just wants to...
Yeah, just a very quick additional point to the ones that Louise has made, which I hope will offer some reassurance to Alice. Yeah, I completely understand your perspective, Alice, that people are under pressure, organisations are under pressure financially. But, I think much of this is about recognising and coordinating and strengthening what we're doing already. It's not about doing lots of new things. And it is also important to recognise that, as I see Marmot, it's about emphasising the importance of prevention and early intervention, and sometimes invest to save. The upshot of all that is that you actually bring about significant savings downstream. And I think that's one of the reasons I think this is really important. It's getting those building blocks operating in the right way. Many of those building blocks are influenced by, or directly in the gift of the council to provide. So we have, I think, just to see this as a way of coordinating, pulling together and giving more impetus to many of the things we're doing already, and particularly that work on prevention and early intervention and investing to save.
Thank you, Stephen. I think that's very true. Philip.
Lovely, thank you, Chair, and thank you, Louise, for your presentation. It was great, and certainly I want to endorse the proposal that you've made. I think a workshop would be excellent to understand this just a little more, because I would see us also as kind of champions for this across our respective sectors, and as part of a kind of an active systems partner. And of course, it gives us a really important framework for how we address health inequality. And I see this as a great opportunity. I'm coming at this as one of the members from the VCSE voluntary sector. But actually, this gives us a great framework, one, to illuminate and to understand what doesn't exist, but also potentially to strengthen applications, to bring more funds into the borough so that we can readily address health inequality. So completely endorse it, and really look forward to being on the journey. Thank you.
Thank you. That's great to hear. And yes, I agree. We could do this without the sort of Marmot label. We could do certain bits of it, and we could review it. But as you say, gives, I think, that focus as well as that support. It gives that kind of profile as well. And, you know, Institute of Health Equity will sort of publish a report, publish their take, publish it online. And so we'll have things that, you know, you'll be able to refer to in funding applications. And it's really, you know, Institute of Health Equity will say how sort of forward thinking we are as a council, that the usual places they work with, you know, Leeds, Liverpool, places that are much more deprived overall. So actually, you know, they are very complimentary of us doing this work as a place that is, you know, healthy and affluent on the face of it. And it's quite a different approach for them, actually. So we're sort of learning together.
Thank you very much, Louise. And I also think it's something about a cultural change and valuing each individual as an individual who is important. And that's something that's very close to my heart. And I think it's very important for Marmot to realise that we value each individual and give everyone the same opportunities. So thanks very much indeed.
Thank you, and we'll go about next time for a workshop.
Okay, we've got some recommendations. Looking quickly for them. And we've got to note to, but we've got to agree to 27 for a workshop and partnership groups working with the Institute to develop system-wide partnership approaches to 2 or 3 Marmot principles. Are we all in agreement?
We are, I'm sure, but I just wanted to say that although Marmot is a name that, as Louise said, can cause some confusion with furry animals and Marmite, it's in many ways a relief he wasn't called Smith or Jones. Otherwise, we'd be becoming a Smith or Jones place, which is not quite so good.
Thank you very much, Louise.
Super. Thank you, Sir.
Okay, so now we're going to move on to the ICB briefing, and that's Ben.
Thank you very much. So there are several developments that I thought would be helpful to highlight to the board out of the report, and particularly given the rapidly changing national NHS England and the local commissioning and leadership arrangements in the NHS, which are literally changing by the day sometimes. So in the letter that Jim Mackey, the NHS England Chief Executive, sent out on the 1st of April, this set out a requirement that each ICB provides an outline plan by the end of May for how the ICB will operate within a reduced running cost budget, reduced down to £18.76 per patient. And to put that into context, that represents an average reduction of 50% running costs for ICB, so very significant really. There is also a model ICB blueprint document received in early May, just a couple of weeks ago, which has provided a pretty clear direction of travel for ICBs as strategic commissioning organisations. So that's improving population health, reducing inequalities and ensuring access to more consistent high quality healthcare. It's also quite clear that some of the functions we currently discharge as ICBs will change significantly over the coming months and years, and along with the level of resource that we're allocated to do those tasks. So as I say, more focus on that strategic commissioning and a transfer over time of some of the other functions that we do and activities to other capable system partners, and that's a process that's likely to take a period of time as we sort of develop that plan with partners. So works are also being carried out across the region to determine the right size of the future ICBs. NHS England has set out some principles to guide that, including that geographical boundaries should pay a due regard to local government devolution, with each local authority only having one ICB covering their area, and populations covered by ICBs not being smaller than 1 million. So in light of that, the Bob and the Frimley ICB boards have met and agreed to support a programme of work to enable the two organisations to come together to develop a shared vision of the future and a joint plan for how we'll work together. And a joint transition executive has been formed by the two ICBs, which is now overseeing that work with representatives from the two organisations. So that's very much the sort of start of a journey, really. We're also working with the regional NHS England team and other ICBs in the South East region to identify other opportunities for collaborating and for doing what we do more efficiently, taking out any duplication in order to sort of work within those reduced running costs. So as I say, that's very much the start of this work. It's going to be taken forward at pace over the coming weeks and months, and as this progresses, we will of course keep this board informed with regular updates. So sort of linked to this, one of the items on the report on the delegation of specialised commissioning, which describes how the commissioning of specialist services that are usually commissioned at scale at a regional level were due to be delegated to ICBs. However, we've been informed in the last 48 hours that this is now being paused following the announcements about NHS England and the ICB reconfiguration. So that section of the report is actually no longer accurate, unfortunately, and we'll update again on this, of course, as soon as we have more information. One of the things that has completed as reported is the annual NHS planning round for 25-26. That's more or less complete now, with the final BOB system plan having been submitted to NHS England at the end of March. So just as a reminder, this is the annual process that the ICB coordinates, through which we agree with the NHS Trust and other providers and partners as a system how financial resources are allocated to provide the health services that we're required to provide over the coming financial year. With respect to collaborative working at place, the NHS and the local authority partners across Berkshire West continue to meet monthly to discuss areas of common interest and to oversee shared programmes of work. A workshop involving all the partners, including Health Watch and voluntary sector representatives, was held on the 23rd of April. The key areas that were discussed likely to be included in this year's work programme include the continuation of the community wellness outreach programme, which I know has been very well sort of supported here and by local partners. There's further work around same-day access to care and enhancing multidisciplinary care planning for patients who might otherwise be at risk of a deterioration in health and or a hospital admission. The work programme is currently being reviewed with the new focus on neighbourhood health and the latest NHS England guidance on neighbourhood health, which I referred to earlier. This was also discussed at the Public ICB board this week, which Susan also attended, and this provides a great opportunity for co-production locally, I think, and for incorporating a lot of the work we've discussed this evening, such as the Marmot work, which is very, very relevant to that prevention agenda and that local delivery of healthcare. And we'll be developing a programme to enable this collaboration to thrive and to enable places to drive this forwards. And again, I'll continue to provide regular updates on this work to the board as it progresses. Happy to take any questions.
Ben Prue.
Not really a question. I thought local authorities had it hard, but so, it's ridiculous. I'm looking at the report. I'm a little bit. It's a bit like Marmot, where you look underneath the surface and find different things. It says in your planning that you're estimating population growth to 2930 is 1.3%. That is clearly not going to be the case. I mean, it's just so obvious. We've got so much extra housing. If you look at how our population has grown, it's 15%, yeah, in the last 10 years. It's going to go on at the same sort of rate or even more in this area, and it's going to cause real problems. So, coupled with the bit lower down that says that the current system deficit position is 52 million is going up to 722 million, even with it. It's sort of like you'll have to laugh, because if you didn't laugh, you'd cry, yes. It's so obviously not a sustainable position for anybody to be in. I feel really sorry, and I'm sorry that you're being mucked about on this change to the specialist stuff, but it had to happen because you couldn't possibly do all the things you're being asked to do at the same time. I just hope that somebody gets an actual grip on reality and that there's a sustainable way forward for you, because I just can't see how this is going to work. There just isn't enough resource in the system for you to do anything like what you need to do, and the consequence of that is that you are being asked basically to shed things and give them to other people who are not being given any resource to do them.
Yeah.
So that it's just not going to work. And we're all going to have to get to grips with it somehow and see how we can minimise the worst impacts of it.
Yes, yeah, I think there's reality, and I mean, it seems if we're thinking of going in with Frimley, it's basically the two will go into one, and half the people we said goodbye to. You know, so everyone will be doing twice as much in theory as they were doing, because they'll be covering twice as much work. So it just seems inoperable, but that's you know that's the sadness of the situation. But have we got any more questions? Well, thank you for coming, Ben, and thank you for saying this. And I mean, I hope your job stays. Because I'm sure all you and your colleagues, you know, you just don't know, do you? And that's a very hard you know, thing to have. So, you know, we wish you all the best.
Thank you very much.
Okay, thank you. So now we've got looking at the forward programme, I believe. So Madeline and I looked at July and September and thought we were quite busy. Has anyone got anything else they want to add to it? Because I mean, certainly those two look fairly full now without adding anything more. November, January still got things, but that's somewhere away. But has anyone got anything that's important to add at the moment? Alice.
Chair, I just wanted to ask about Royal Berkshire Hospital NHS Foundation Trust update. What are we expecting from that one? Is it about how the hospital is running, or is it about the new build? It would be nice to have some clarity about what is it about. That's possible, sir.
Yeah, and I think, I mean, certainly for me, the new build is not happening at the moment. There might be some information about that, but also about how the hospital is surviving. And certainly, as we go into the winter, we have to start thinking about the winter pressures and so on, and how we can tackle them. And I think it's important for us to have feedback on that, because it is a very important time for the hospital.
Thank you.
Stephen.
Not a suggestion for anything to add, but just to applaud the fact that in September's meeting we're going to be looking at social care future, which is a really good initiative, and I'm very pleased it's coming to the board.
And I hope we have some of the people who use our services to present that, because that was so powerful last time we had it that I think, you know, it's very important that we do. Okay, I think that's everything. So thank you all very much for coming, and we'll see you again. Well, there's obviously a June meeting, but in person, or some of us in person anyway, in July. Okay, thanks very much.